All right, hello everyone, and welcome to our July session of the seminar series, which we are presenting jointly with KT Canada and the SPORE Evidence Alliance. So we have with us today Ms. Lashanda Skerritt and Dr. Alex Corral, who will be each presenting a 20-minute presentation with 10 minutes for question and answer after each presentation. So first we will have Lashanda Skerritt. If you do have questions, please send them via the chat box, and if you send them to everyone, that's perfect, so then everyone can see them, and I will read them out for the presenter. I have also muted everyone on entry, so you don't need to worry about that. So let's get started. So we have with us first Lashanda Skerritt, who is an MD PhD candidate and a Vanier Scholar in the Department of Family Medicine at McGill University. Lashanda's doctoral research aims to produce much-needed evidence to support high-quality reproductive health care for women living with HIV in Canada. Drawing on data from a longitudinal cohort study designed by, for, and with women living with HIV, her research applies community-based participatory approaches and innovative patient engagement methods to understand gaps in reproductive health care and strategies to address them. Lashanda's presentation will focus on the use of fuzzy cognitive maps as a tool for capturing stakeholder expertise and translating knowledge into action. So without any further delay, please welcome Lashanda Skerritt. So Lashanda, please go ahead.
Thank you, Megan. Thanks for the introduction and also for the opportunity to present today. It's my pleasure to be here and be able to share with you a presentation about fuzzy cognitive maps and their use as a tool for integrated knowledge translation. So the title of this talk is Identifying Reproductive Health Priorities and Factors Promoting Women's Satisfaction with HIV Care in Canada. And I'm going to be focusing on fuzzy cognitive maps, but contextualizing it within my doctoral research so that you have a sense of how they're used in practice. Before I begin, I do want to acknowledge that I'm giving this presentation from the traditional and unceded territory of the Kanien'kehá:ka, and I think it's particularly important to reflect on this, particularly as we're in a time of really thinking about systemic racism in our society. So I do want to recognize and respect the Kanien'kehá:ka as the traditional custodians of the lands and waters where I live, which is commonly referred to as Montreal. I don't have any conflicts of interest to disclose. In terms of the learning objectives for this presentation, my hope is that at the end of the talk, you'll have a sense of the basic properties of fuzzy cognitive maps, that you'll be able to describe the process of stakeholder engagement using fuzzy cognitive maps, and that you'll also have some knowledge to be able to explain their role in the integrated knowledge translation framework. So as I mentioned, I'm placing fuzzy cognitive maps in the context of my own doctoral research, which aims to address reproductive health care gaps for women living with HIV in Canada. So I'll talk a little bit about the objectives of the project and the process that involves community engagement, virtual fuzzy cognitive mapping for stakeholder engagement, an analysis plan for the fuzzy cognitive maps and expected results because this project is ongoing. And then I'll end with some conclusions about fuzzy cognitive maps and how they fit into the integrated knowledge translation framework. So the problem that my doctoral research aims to address is related to care gaps for women living with HIV in Canada. And this figure, which is from a recently published study led by my colleague Nadia O'Brien, I think illustrates the magnitude of this issue. So in this study, we looked at 3 indicators of comprehensive healthcare for women living with HIV. Those were having a discussion about reproductive goals with a healthcare provider, so that's inclusive of family planning, contraceptives, pregnancy planning, achieving an undetectable HIV viral load, and having pap tests within the recommended screening time frame. So those were the indicators for women under the age of 50 years of age. And what we found was that over half of women in the study had at least one.
Shonda, we can't hear you all of a sudden, or is that just me?
I could still hear you. Me too.
Everyone else can hear. It's just me. Okay, continue, please. Sorry, I'll redo my sound. Sorry about that.
Okay. Oh, I hope we're able to figure it out. Yes. So what we found in this study was that over half of women had at least one gap in their care, and that reproductive health care represented the largest unmet need, and that's this yellow circle in the figure. So to address how to address this issue of unmet reproductive health care needs, the objectives of the current study are to first identify the factors that promote women's satisfaction with their HIV care, and then once we have a sense of what those factors are, to determine how women prioritize their reproductive health care among all of those other factors that they consider. So the project fits within an integrated knowledge translation framework, and this is where fuzzy cognitive maps become particularly useful because they empower us as researchers not only to capture the knowledge of our stakeholders, but also to systematically and robustly include that expertise in the analysis of our data. The project fits within a larger study, which is the Canadian HIV Women's Sexual and Reproductive Health Cohort Study. This is a community-based longitudinal cohort study that's really driven by women living with HIV. And the project established a network of stakeholders that included women living with HIV, community partners, healthcare providers, and researchers, which really facilitated our ability to identify the stakeholders and engage with them in this project. And the CHIWOS study involved 3 points of data collection between 2013 and 2018 at 18-month intervals, and data were collected from British Columbia, Ontario, and Quebec. In total, 1,422 women living with HIV completed the baseline survey, and the retention rate over the course of the study was 81%. This figure illustrates for the project, which involves fuzzy cognitive mapping, the points of stakeholder engagement, which were, as I mentioned, facilitated by being situated within CHIWOS. So we have ongoing points of feedback and engagement with stakeholders, which include healthcare providers, women living with HIV, and community partners. And then what I also wanted to mention here in the timeline is that with the pandemic, with COVID-19, it really challenged us, as it did for a lot of researchers, to think about how we're conducting our research and how it can happen within the current realities of physical distancing. And so the project, which was initially envisioned as being an in-person, or the mapping sessions, which were envisioned as being an in-person group brainstorming exercise, have now moved to being planned virtually. And so at present, we're planning to conduct these fuzzy cognitive mapping sessions virtually, where they will be co-facilitated by a peer research associate who is a woman with HIV trained in the study protocol. The project involves 2 phases. The first phase is the actual construction of the maps, the fuzzy cognitive maps. And then the second phase involves using those maps as conceptual models to analyze the longitudinal survey data from CHIWOS. And there are 2 real value added that the fuzzy cognitive maps bring to the analysis of our survey data. The first is that we're actually able to integrate the expertise of our stakeholders. And then secondly, we're able to approach our analysis of the longitudinal survey data with a conceptual model or a theoretical framework. So we're really theory-driven in our approach to analysis as opposed to being solely data-driven, which is an important part of quantitative data analysis and interpretation as well. So in the actual construction of the fuzzy cognitive maps, it's an iterative process where we're integrating two sources of knowledge. The first is existing scientific literature. So we're beginning with a map that's based on a published systematic review of the aspects of healthcare that are most valued by people living with HIV in high-income countries. This review was published in 2016, but what we know is that the perspectives of women living with HIV are largely underrepresented in HIV research. And a lot of this has to do with the fact that in high-income settings in particular, and in the global north, HIV is largely perceived as a disease impacting men who have sex with men. And so women's perspectives aren't represented as much as they should be. So that necessitates that we update the existing literature with the context and perspective of women. Here I am showing you what an actual fuzzy cognitive map looks like. This one is from a study published in 2007, where the authors were integrating conventional science or medicine and indigenous perspectives on the determinants of diabetes. So I present this map to you to show some of the basic components of fuzzy cognitive maps. There are really three. The first are nodes. So here, the nodes represent different factors in the model or the system. So the main outcome factor in this study was diabetes, which is represented here in a gray node. And then all of these other nodes are representing explanatory factors in the model. The second component of the maps are arrows, which represent causal relationships. And then thirdly, each arrow has a value that's associated with it, which is meant to reflect a fuzzy or a rough estimate of the strength of that relationship. So here, those values are scaled between -1 and 1, where a negative value would mean, for example, here that an increase in physical activity causes a decrease in diabetes, and a positive one represents the fact that an increase in body weight very strongly leads to an increase in diabetes. So for the project, the actual process of constructing the maps involves recruiting 24 women living with HIV who participated in SHIWOs, with the additional criteria that because these mapping sessions are happening virtually, women have to have access to a device that connects to the internet. Then we do individual virtual fuzzy cognitive mapping sessions. So that involves with a woman living with HIV and facilitated by our peer research associate, we construct the map in real time based on a series of questions and prompts, which I'll present to you in a bit. And then after the 24 individual mapping sessions have been completed, we develop an aggregate map, which we then present back to the women who created the maps in a virtual group discussion. And the idea here is to check with women living with HIV that the aggregate map still reflects their understanding of the issue, and if it doesn't, it's an opportunity to revise the map before we actually use it to analyze our data. And then finally, the analysis involves a Bayesian approach where we're able to integrate the prior estimates that we obtained from the map with the evidence from our epidemiological study. So these are the prompts that are sort of the questions that we asked during the virtual fuzzy cognitive mapping session. So the first part of the discussion involves asking women to define what satisfaction with HIV care means to them. And we put satisfaction with HIV care and the definition in a node on the map. Then we ask women to list all of the factors that they believe positively or negatively influence satisfaction with HIV care. And then all of those factors get placed in nodes on the map. And then for each factor, we ask women to identify all of the factors that that factor causes, and we draw arrows between each of those factors to represent those causal relationships. And then we ask women for each of the arrows to assign a weight between -5 and 5 to indicate how strong that relationship is. So a 5, for example, would mean that this factor almost always causes the other factor, whereas a 1 might mean this factor rarely causes this factor. And then there's an opportunity at the end to look at the map as a whole, revise it if needed, and then once women feel that it is accurate of their understanding, then the mapping session, the individual mapping session is done. So this is a theorized fuzzy cognitive map that shows what the end product might look like after an individual mapping session with a woman living with HIV. And this isn't based at all on any fuzzy cognitive mapping that we've done. It's basically just illustrating some of the relationships that we're interested in exploring. We're interested in seeing whether the relationship that women have with their healthcare provider emerges as an important factor and how strongly that's related to satisfaction with HIV care. Some of the other relationships that we're interested in looking at is the provision of reproductive health services and how that is related to satisfaction with HIV care. So this is just illustrating what a map might look like and what some of the factors are, factors and relationships are that we're interested in exploring. So after the 24 individual mapping sessions have been completed, we create an aggregate map, and then we present that map back to the women who created the individual maps. And the idea here is that we want to ensure that the concept and the connections and the priorities in our conceptual model accurately represent what they've shared with us. If they don't, we revise the maps accordingly. The actual analysis plan for the fuzzy cognitive maps is really analogous to a network analysis. What we're trying to do is identify not only the direct relationships that women described in the mapping sessions, but we also want to include in our analysis the indirect relationships. So for example, women might have described that a factor F causes factor E, and factor E causes factor A, but what's implied as well here is that factor S is indirectly related to factor A. So we have to kind of include those indirect relationships in our analysis as well. And then what we also do is that instead of considering each connection or each arrow independently, we want to adjust for the other factors in the map. So it's a type of model adjustment for boundaries of relationships so that we can get those fuzzy estimates that consider the entire system. So the second phase of the project involves actually analyzing our CHIVOS survey data. So keep in mind the rationale for actually doing phase 1 or constructing the maps was that we are able to actually capture stakeholders' knowledge of the system. So women living with HIV are stakeholders in their healthcare, and we want to be able to capture their knowledge and understanding in our analysis. And then secondly, we also want to approach our analysis of epidemiological data with a theoretical or conceptual framework. So when we analyze our data from the study, we're interested in the outcome, which is the response that participants had to the survey question. Overall, I'm satisfied with the care I received from my HIV clinic or doctor. And this was rated on a 5-point Likert scale. And the predictors or the covariates that we include in our model are the factors that emerged from the fuzzy cognitive map and that were measured in our survey. And then what we're able to do using Bayesian inference is actually combine the prior estimates or the rough estimates from our fuzzy cognitive map, which integrated scientific literature and the expertise of women living with HIV, with our evidence from the epidemiological study. And so we're able to obtain a weighted estimate of the strength of those associations, and that posterior estimate is combining the scientific literature, the expert knowledge, and the evidence from the epidemiological study. So what we expect in terms of results from this study is that we anticipate that reproductive health care will emerge as a factor that's important in promoting satisfaction with HIV care, but that it will likely differ with other factors, particularly ones that represent women's social and structural context. And this is because we know that women's social and structural context influence the ways in which they navigate the healthcare system and their health outcomes. And then we also anticipate that this will demonstrate an approach to knowledge synthesis where we're able to integrate experiential expertise of women living with HIV as well as epidemiological study data. So in conclusion, fuzzy cognitive maps allow researchers to integrate stakeholder knowledge in the evidence synthesis process. They support a theory-driven approach to analyzing epidemiological study data, which is important as we want to be more theory-driven as opposed to data-driven in our analysis and interpretation. And fuzzy cognitive maps align with an integrated approach to knowledge translation because it allows us to engage stakeholders in a part of the evidence synthesis process, which is the data analysis phase, where it's sometimes difficult to do that, particularly for epidemiological studies. I do want to acknowledge the other people who are involved in this work. They include my supervisors, my thesis advisory committee, the CHIVOS research team, peer research associates, and community advisory board, the funders of this project, and all of the women living with HIV who are participating. So with that, I thank you, and I'm happy to take any questions if there are any.
Thank you, Lashanda. That was fantastic. All right, so I will get us started with a question here. What differences in the virtual format of the fuzzy cognitive mapping sessions do you anticipate compared to the in-person format that was originally planned?
Yes, so thanks for that question, Megan. I think one of the things that I anticipate will be different in doing these sessions virtually is that in the group format, I anticipate or I imagine that it's a bit easier to maintain a level of high engagement with participants because it's a group setting, it's kind of a continuous discussion, and actually in the in-person format, there's an opportunity for women to actually illustrate their maps themselves, whereas in this virtual format, what's happening is that there's a discussion happening and the maps are being constructed by a co-facilitator or myself in real time. And so I think it is likely that it's a bit more challenging to maintain the same level of engagement. And so what I think is a way to kind of approach that challenge is to create in the lead up to the session and the follow-up and in the group discussion, a series of kind of points of follow-up and engagement. So that means before beginning, we might send the participants that literature map that looks more kind of, it's like gray and it's in black and white and maybe looks a little bit more dull because it's just based on papers. And then after the actual individual sessions, we're able to share with women the individual map that they constructed. And there's a point to actually visually see the transformation that their own lived experiences gave to the map. So it's almost like kind of giving life to that evidence from the literature. So it might be, with more color or kind of illustrated in a way that shows that some value was really added from their lived experience. And then following up on that, I think that helps to kind of lead into our group discussion where that aspect of, the contribution can be visually seen is made. So I definitely anticipate that engagement is a challenge in the virtual format. And so creating ways to maintain participant engagement throughout the phases, I think is a way to kind of counteract that challenge.
Hi, Lashanda. Can you guys hear me?
Yes.
My sound just cut out. Can you see Jamie's question?
Oh, yes, sorry. Okay, so I see Jamie's question, which is how did you arrive at choosing fuzzy cognitive maps over, say, other learning network models like epistemic network analysis or other forms of quantitative ethnography? So that's a really good question. So the way that I was introduced to fuzzy cognitive maps was really learning about their use and participatory research with marginalized communities. And part of the utility of fuzzy cognitive maps versus some of the other methods that you mentioned is that illustratively, they're incredibly kind of simple and easy for people to use without having really any kind of understanding or knowledge about complex models. So that was part of their application, that they're used in different cultural contexts, different language contexts, because their simplicity and kind of being able to communicate across different contexts and cultures and educational levels and settings. So that was how I first came to know about their usefulness and application, and to also kind of promote its use for marginalized communities without adding, I guess, additional complexity for participants.
Thank you, Lashanda. Sorry about that. The phone lines have been just keeping us on our toes a little bit today, but I think everyone who's tuned in via their computer, their sound seems to be fine. So thank you for handling that very gracefully. Okay, we have another question from Reen. She says, hello, Lashanda. Thank you for this great presentation. Is there any software that you can use during the session, or is there an advantage to drawing the maps by hand?
Thanks for that question, Reen. It's a really great question. So there are a few different softwares that can be used. And the more popular ones are called YEd, and the other is Mental Modeler. And compared to actually drawing the maps out by hand, the advantage of using software is that it automatically allows you, or not automatically, but it more easily allows you to actually go from your constructed map to analyzing the map, because the softwares can basically take your map from the illustrative format into a matrix format, which is actually what you kind of need to do the sort of network analysis that I mentioned. So that's the advantage of doing it digitally. But the advantage of doing maps by hand, I think, as well, is if you are in a situation in which participants are able to do that, it is part of the kind of engagement aspect to be able to just illustrate your own knowledge, your own cognitive understanding of a system, and see how it looks constructing it yourself. But I think there are kind of positives and negatives to both. If you do the maps by hand, in the end, in order to do a lot of the analysis that's needed after, you would have to transform that map that's done by hand into a digital map anyway.
Okay, thank you very much. I don't see any other from the audience at the moment, so I think we have time for one more. We have about 2 minutes before we move on to Dr. Corral. So the other one I have for you is the fuzzy cognitive maps will include the perspectives of women living with HIV, but how are you planning to engage the other stakeholders that you mentioned, like healthcare providers and community partners?
So that is a great question. What we've done is that, yes, the maps themselves are reflective of women's understanding of the system, but we also are including a systematic review of the literature and updating those with perspectives. So there are perspectives from other stakeholders represented there, but in addition, we are engaging stakeholders throughout the entire research process. So although their perspectives are not in the construction of the map, they are in the development and the refining of the research question and the study methods, as well as in the actual interpretation of the findings, and then transforming those findings into messaging that's relevant for those stakeholders. So their perspectives are included in different aspects of the study process.
Excellent. Thank you so much, Lashanda. So perfect timing. So thank you once again for your presentation. And I'm just going to switch us over now to Dr. Corral.
Thank you.
Thank you. Okay, so Dr. Corral, if you could share your screen. So while she's getting organized, I will do the introduction. So Dr. Alex Corral is a postdoctoral researcher in the Knowledge Translation Platform of the George and Fay Yee Center for Healthcare Innovation, also known as CHI, at the University of Manitoba. A key focus of Alex's research is to advance the practice of KT for the prevention and management of falls and fall-related injuries in older people. A secondary focus of Alex's research has been to advance the science of KT when it's necessary to inform her KT practice objectives. This includes her current work funded by CHI and the Sport Evidence Alliance, engaging patient and public partners in the design and conduct of a scoping review on the science and practice of James Lind Alliance priority setting partnerships. And I wanted to mention also that both of our presenters today are recipients of the Sport Evidence Alliance 2019 SEED grant. Okay, so Dr. Corral, it looks like we are ready to go. Thank you.